In this chapter, we'll discuss water, electrolytes, and acid-base balance. So in medical care, restoration of fluid balance is often the first priority in reestablishing homeostasis. So the big thing we're focused on is what's known as hemodynamic stability, which is we have to make sure the patient has adequate fluids for adequate blood pressure and circulation. Now the volume, composition, and distribution of body fluids can have profound effect on cell function. And so one of the things we'll talk about is electrolytes, which are substances with an electrical charge that dissociate into positive and negatively charged ions. So remember, we have our positively charged cations and our negatively charged anions when dissolved in water. Now looking at some of the functions of water. So water transports nutrients and all body substances. It transports and excretes metabolic waste, supports shell shape and structure, lubricates friction generating surfaces, sustains normal body temperature, helps maintain electrolyte balance, and is essential for the processes of digestion, absorption, and excretion. So looking at total body water, so it accounts for 75 to 85% of total body weight at birth, accounts for 50% of total body weight for females, and 60% of total body weight for males. And again, this just has to do with the amount of lean mass at baseline. So again, this is influenced though by the total amount of lean mass or fat mass, with a lean adult being between 60 to 70% total body water, and an obese adult being 45 to 55%. So again, we have our baseline differences in muscle in males and females, but then if they have large amounts of muscle mass, I don't know if anybody saw that, for example, there was the CrossFit had a competition this weekend, right? If they increase their muscle mass, male or female, they'll increase their total body water. Now, fat tissue has the lowest percentage of water, so it's about 14-ish%, give or take. And so metabolically active muscle cells, so what you're thinking of is, again, this is typically going to be skeletal muscle, although also our smooth muscle like organs will have the highest percentage of water, as seen by beef jerky or anytime you cook meat and you see how much it shrinks with a loss of water. So here we just have a nice graphic, so looking at the distribution of water as a percentage of body weight, and again we have our different compartments. So we see fat and dry solid, intracellular water, and then extracellular water. And so what you can see is that the percentage of total water changes, right, as we reach adulthood. So body water content declines throughout the lifespan and often falls below 50% in the elderly, whereas athletes will have a higher percent total body water than non-athletes. Now the proportion of body weight accounted for by water varies with age and body fat, but there's little day-to-day variation of percent body water in an individual. So through different phases of the life, so for example from your 30s to 60s, it's going to stay relatively the same, and then into your 60s and beyond it will decrease. But at whatever life stage that is, you're not going to see a lot of day-to-day variation. So you shouldn't be 50% one day and 60% the next day. That means something's off with your body. Now again, if it's a different life stage, that's different. But like I said, a day-to-day variation should not be occurring. So here we can see the effects of dehydration. So again, you can see as we increase the percentage, these symptoms increase in significance. And it begins with thirst, and then increasing thirst, discomfort, and poor appetite, decreasing blood volume, impaired performance, nausea, poor concentration, thermoregulation issues, dizziness, labored breathing, increased weakness, spasms, delirium, and then inability of decreased blood volume to circulate normally, failing renal function, and eventually leads to death. So a loss of 10% of body water or more may lead to damage to essential body systems, and a loss of 20% of body water may cause death. Now again, I know you've heard that we can go up to 3 days without water, but it's really climate dependent. It's quite hot down here in the south, but so adults can live up to 10 days without water. Now I'm not saying there won't be lasting health effects or severe issues, but again, depending on the climate, the amount of sweat, thermoregulation, etc., right? People can go a significantly long time without water, and children possibly even up to 5 days. Now, again, I'm not recommending this, but just realize, right, this rule of 3, it's a little more complicated than that because there's a lot of other variables to factor in. Now, our fluid is in different compartments. So we have our intracellular fluid, and so this is contained within the cells and accounts for 2/3 of body water. And we also have extracellular fluid, and this is found in plasma, lymph, secretions, spinal fluid. This is 1/3 of body water and has 3 compartments, including interstitial, which surround the cells, intravascular, found within the blood, and transcellular, which is found in secretions within the organs. Now, the way I like to envision or I think of extracellular fluid is it's kind of like, so if you have water balloons, and we know that if you store water balloons in a bucket, due to friction, they'll pop. So what you have is you have a bucket full of water balloons. The water balloons contain the intracellular fluid. But to make sure they don't pop, you should fill the bucket with water, and this should take up the remaining space, not taken up by the balloons. The extra water in the bucket is the interstitial fluid. So again, that's kind of how I like to visualize the difference in the 2 compartments, and then the 2 specifics, right, which is your within the cells and the interstitial. Now again, so here we have a nice little chart that shows you, again, not only these compartments, but the volume of fluid. So this is our absolute, which tells us our volume, and then our percentage, right, which tells us, again, how much is in each compartment and how this affects body weight. So some things to consider with these different compartments is we'll talk about what's known as third spacing. So water will leak into the interstitial spaces, causing hypovolemia, because the fluid moves or shifts from extracellular fluid into the interstitial space. And so what's going to happen is you're going to have a low volume of blood because the fluid is now in the wrong compartment. So when we say hypovolemia, although you're having fluid, it's in the wrong compartment. In edema, fluid accumulates underneath the skin and in body tissues. And so here we actually may have hypervolemia. And in ascites, fluid accumulates specifically in the peritoneal cavity. And so this is usually accompanied by or due to liver disease. So looking at the movement of fluid. So fluid status in the body is in a state of dynamic equilibrium, which is to say that it doesn't just sit there, but rather it's constantly moving, although the volume and concentrations remain relatively the same. So a couple molecules in, a couple molecules out, and back and forth and back and forth. Now, the amount of water taken in daily is approximately the same as the amount of water lost, assuming that all homeostasis mechanisms are functioning normally, right? So you should get thirsty, you should consume additional fluid. If you consume too much fluid, the kidneys should excrete additional fluid, and so on and so forth, and in this dynamic equilibrium, and things stay balanced. Now, fluids can move freely between compartments via osmosis and filtration. So with osmosis, it's just the water that's moving between compartments, and with filtration, both water and the solutes are moving between the compartments. So looking at the movement of fluid, there's 2 types of pressure that influence the movement of water and solutes. So we have osmotic pressure, which is the pressure at the cell membrane. And so movement of fluid across a semi-permeable membrane from an area of low concentration to an area of high concentration. And so what that means is that the way the easy mnemonic for this is that water wants to move to water down something. So it wants to go and dilute something where there is high concentration. So we have what's known as oncotic or colloid osmotic pressure. So this is a form of osmotic pressure at the capillary membrane exerted by colloids, which pull water into the circulatory system. This is what pulls water or holds water in your blood vessels. In this case, right, when we're referring to colloids, this is large protein molecules. The most famous colloid you're probably familiar with is milk. Now, in this case, right, the protein molecule is albumin, which is too large to diffuse across the membranes, and so it pulls water back in to dilute the albumin in your blood. So this helps to retain water within the blood vessels, preventing its leakage from plasma into the interstitial space. And so albumin again is drawing this water back into the blood from the tissues at the venous end of capillary beds. Now what we see is that patients with low plasma protein, so those that have low amounts of protein in the blood or hypoalbuminemia, will develop water leakage into the interstitial spaces, causing third space fluid buildup. So if you are having severe inflammation and a low protein status, it is possible that fluid will leak out of your blood. Now we also have hydrostatic pressure. And this is the pressure exerted by the fluid on the membrane, which forces fluid into the tissues. And so fluid is pushed from an area of high pressure to an area of low pressure, i.e. this is the pressure of the blood on the arterial walls, or blood pressure. So this is actually what's the pushing force that pushes open the blood vessels, and this opposes or is the opposite end of osmotic pressure. So one pulls fluid into the blood and one pushes fluid out of the blood vessels. So hydrostatic and osmotic pressure work together to move fluid out of the blood and into the interstitial areas at the arterial end of the capillary, and restore fluid back into the blood at the venous end of the capillary. And this is known as Starling's law of capillaries. Now looking at the physiological regulation of fluid and electrolytes. So looking at the thirst mechanism. So thirst sensation controls water intake, again in healthy individuals. And cellular dehydration and decreased extracellular fluid play a role in stimulating thirst. And so sensors within the interstitial fluid trigger the hypothalamus to stimulate thirst and increase fluid intake. Now the problem is the sensitivity to thirst decreases in the elderly and leads to a higher risk for water deficits and dehydration. So they're just not as receptive to that sensation that's telling them they should be consuming additional fluid. Now looking at renal function. So hydrostatic pressure increases when blood volume increases, which increases the pressure. So water is what's called a non-compressible fluid. You may have heard the old wives' tale that if you hit water at high speeds, it's like hitting concrete. And there's some truth to that. It's a little more complicated because it has to do with the shape of the object and the surface area. But the reason why that phrase exists is because water is what's considered to be non-compressible. So water has a specific density. Now what happens is that even when you try to exert pressure on it, the density of the water does not change. And this just has to do with its molecular arrangement. So what's interesting is like the water will not get any thicker when you put pressure on it. Now you can increase the pressure, right, like at the bottom of the ocean, etc. It's very, very high pressure, but the density of the water doesn't really change, right? It's not harder to swim through. It doesn't turn the water into jello because it's squeezed so tight, etc. So the same thing happens, which is your blood vessels are a closed system, right? There should be no hole in your blood vessels, otherwise something's gone terribly wrong and you're injured. So I can't compress the fluid in your blood vessels. So what happens is the pressure goes up, just like it would at the bottom of the ocean. This results in more fluid moving from the capillaries into the renal tubules, and then fluid should be excreted as urine by healthy kidneys. So assuming the kidneys are healthy and undamaged, right, this additional fluid will then be pressed out and then lost through urination. Alright, so we're going to continue looking at the physiological regulation of fluid and electrolytes now. This specifically, we're going to take a look at the hormonal influence, and I cannot stress the importance of understanding this system, because again, you're going to see this multiple times when we talk about renal health, we talk about fluid balance. So this is really important. I would really focus on this, especially now, as it will pay dividends going forward. So when we're talking about hormonal influence, we're looking at the renin-angiotensin-aldosterone system. And in this system, so decreased extracellular fluid volume causes low hydrostatic pressure, which stimulates baroreceptors or pressure receptors within the blood vessels. The kidneys release renin, which stimulates the conversion of angiotensinogen, which is a precursor, to angiotensin 1. Angiotensin converting enzyme converts angiotensin 1 to angiotensin 2. And increasing amounts of angiotensin II stimulate the release of aldosterone from the adrenal cortex. Now, aldosterone influences the kidney to retain sodium, which attracts fluid and pulls fluid back into the blood, and then increases the amount of fluid in the blood, returning pressure back to normal. So here you can see a visual example where, again, we're looking at the management of blood pressure and fluid regulation, and this system's goal is to pull fluid back into the blood vessels to increase the pressure. Now you also saw on that diagram vasopressin. So vasopressin is a hormone released by the pituitary, also known as antidiuretic hormone. Now, increased osmolality, or increased concentration of extracellular fluid, aka your blood is getting too sludgy or has too much stuff in it, or decreased total blood volume, can stimulate the release of vasopressin, which signals the kidneys to conserve water. Vasopressin also causes fluid to be reabsorbed in the kidney tubules, increasing blood volume and lowering blood osmolality. So what you're seeing is that aldosterone and vasopressin have similar functions, but they go about it in different mechanisms. They both result in more fluid being inside the blood vessels. Aldosterone, though, is focused on sodium, which happens to also pull water with it, and vasopressin is focused on the water itself. So here again you can see this interaction where, again, our goal is to reabsorb additional fluid into the blood vessels to then dilute the blood and return the osmolality back to normal. Now, one thing to consider, though, is what's known as water intoxication. And so this occurs as a result of water intake in excess of the body's ability to excrete water, and increased intracellular fluid volume and osmolar dilution causes the cells, in particular the brain cells, to swell, leading to headache, nausea, vomiting, muscle twitching, blindness, and convulsions. And this can be fatal if left untreated. And the people that are at risk for this, so that we're looking at commonly that we'd be exposed to, so endurance athletes who consume large amounts of water or electrolyte-free beverages during events are at risk. Now, just as a technical clarification of osmolarity versus osmolality, you'll see them used interchangeably, and because we're human beings and we're made out of water, it works most of the time. They're technically a little bit different. So osmolarity is the number of osmotically active particles per liter of solution. So here we have our milliosmoles per liter. Osmolality is the number of osmotically active particles per kilogram of solvent in which the particles are dispersed. This is milliosmoles per kilogram, and this is what you'll see in most clinical work. Now, the reason why they're used interchangeably is because in water, 1 kilogram of water takes up 1 liter of space, and vice versa. So because humans are predominantly water, and because we're looking at labs based in water, etc., they're used fairly interchangeably. Things get extremely different, though, when you start trying to dissolve things in alcohol, or you're trying to dissolve things in acetone, like in chemistry. So in chemistry, osmolarity and osmolality play a much bigger role because they're very different from each other. But again, because of the non-compressible nature of water, i.e. it will always take up 1 liter of space, and its weight doesn't change unless you're at extreme altitude, osmolality really wouldn't change, right? So for all intents and purposes, when dealing with humans, they're mostly interchangeable, but they are technically different, so please be aware of that when looking or interpreting data. Now again, looking at osmolality and osmolarity, again we have our formula. So looking at the normal range for bodily fluids, which we said was that 285 to 300-ish, and again we have our equation that we're familiar with. So again, that normal range of 285 to 300, and then for the geriatric population, a little bit more concentrated at 285 to 295. And again, just as a review, so our isotonic solutions are fluids that have the same osmolarity. In this case, they're equal to the blood. A hypertonic solution is greater than 300 milliosmoles per liter. And so when cells are exposed to a hypertonic solution, fluid will move out of the cell, resulting in the cellular dehydration, right? The cell will shrivel. And hypotonic is less than 285 milliosmoles per liter. And when cells are exposed to a hypotonic solution, fluids will move into the cell, causing swelling. Now looking at total body water balance, so looking at fluid intake, so we do have fluid intake from food and beverages. So any food that is fluid at room temperature is considered part of fluid intake, such as ice cream, jello, etc. And then foods themselves, right, will contain varying amounts of water. So it is true, for example, that fruits and vegetables, things like watermelon, etc., do contain a significant portion of water, as in more than 90%. We also have small amounts of metabolic water. So anabolic reactions or building things releases water. But this is relatively insignificant, and so with the exception of some very expensive research purposes, we're not really measuring metabolic water, but we just acknowledge that it exists. So here we can see again foods and their water content and their varying amounts. Looking at water elimination, so we have fluid output through sensible losses, which are visual and measurable. So for example, urine, somewhere between approximately 800 to 2,000 milliliters per day, with normal fluid intake of about 2 liters. Obviously, if you drink more, you will urinate more. Looking at the GI tract and stooling, so about 100 to 200 mils average daily loss. Again, this is not accounting for diarrhea, loose stools, etc. Now we also have insensible losses, so these are not seen or measured. And so here we have things like respiration or evaporation from the skin, and approximately 700 to 900 milliliters per day. So again, if you were in a colder climate, you could see this respiration, but in a warm, humid climate, it's more difficult to visualize this. But again, we are looking at a significant amount of loss through these insensible losses. Now, other abnormal fluid losses may occur. This is things like diarrhea, emesis, aka vomiting, hemorrhage, fistula drainage, oozing, burns, or wounds, gastric and surgical tube drainage, and the use of diuretics increasing urinary losses. So looking at water elimination, so if water intake is insufficient or water loss is excessive, then healthy kidneys will compensate by conserving water and excreting less urine. So the renal tubules increase water reabsorption in response to vasopressin. However, the kidneys can only concentrate urine up to approximately 1,400 milliosmoles, and then hypernatremia or dehydration can occur. So imagine, right, if normal is 300, then looking at 1,400, you're looking at about 4.5 times normal, right, as it is the concentration of urine compared to other bodily fluids. Now, signs of dehydration include headache, fatigue, lightheadedness, poor skin turgor with skin tenting, concentrated dark-colored urine, decreased urine output, dry mucous membranes of the mouth and nose, orthostatic blood pressure changes, aka getting woozy when you stand up, tachycardia or rapid heart rate, sunken eyes, and decreased appetite. Now, one of the ways that we can measure this is specific gravity. So this is the measurement of dissolved solutes, and specifically we're looking at urine-specific gravity. This can be done via urinalysis or urine testing strips. And so increases above normal, right, is how we're going to determine if there's dehydration. So the normal value is 1.01 to 1.025. And if it's greater than 1.025, then there's dehydration. So for example, something like diarrhea. And if it's less than 1.01, then we're overhydrated. Now there's several ways to estimate or determine fluid needs. Again, I don't expect you to know all of these off the top of your head. I would put these in my pocket guide. I can tell you though that for adults, method 1 and method 2 are the most common. And for children, I have probably used method 2 the most frequently. Now looking at osmolality and solutes, which are the products dissolved in the blood. So looking at our different types, we do have electrolytes. So again, these dissociate into our positive cation and our negative anions when dissolved in water. We have our major electrolytes in the body, including sodium, potassium, calcium, magnesium, chloride, bicarbonate, phosphate, and sulfate. And then other molecules that remain stable while in solution, including glucose, protein, urea, lactate, and organic acids. So our major extracellular electrolytes, so these are the electrolytes in the extracellular fluids, is sodium, which is our major cation, calcium, chloride, which is our major anion, and bicarbonate, which is our other major anion in extracellular fluid. Our major intracellular, or within the cell, electrolytes is potassium, which is our major cation in intracellular fluid, magnesium, and phosphate, which is our major anion in intracellular fluid. Now looking at the distribution of electrolytes, so the sum of cations must be equal to the sum of anions within a given compartment. So again, going back to chemistry in Dr. Stebbins' class, right, there should be a balance between the charges. Now changes in either intracellular or extracellular fluid can have major effects on bodily functions. And again, remember these charges and these electrolytes, one of the ways they are maintained with homeostasis is the sodium-potassium adenosine triphosphatase pump, or the NAK pump, which helps regulate these electrolyte contents by actively pumping sodium out of cells in exchange for potassium. So here we can see the normal electrolyte concentration of the serum. And remember, serum is an extracellular fluid. And so then we take a look at our cations and anions, right? These numbers make sense. So we see that there is a high concentration of sodium and a low concentration of potassium, where again here we have the NAK pump. So we can see that the sodium has been pumped out of the cells and into the extracellular fluid, and the potassium, which has gone into the cells, is in low concentration in the extracellular fluid. So looking at sodium, we have our major cation for extracellular fluid. So the normal serum concentration is 136 to 105 milliequivalents per liter. And so it functions in the regulation of extracellular fluid and plasma volume, neuromuscular function, and the maintenance of the acid-base balance. And secretions such as bile and pancreatic juices contain substantial amounts of sodium. Now, severe hyponatremia or severe low sodium can lead to seizures, coma, and death. The NAK ATPase pump is the active transport system that works to keep sodium out of the cells through the exchange with potassium ions. So sodium is readily absorbed from the intestine and carried to the kidneys, where it's filtered and returned to the blood to maintain proper levels, with 90 to 95% of sodium being lost through urine, and the remaining 5 to 10% lost through feces and sweat. In a healthy adult, the amount of sodium excreted is equal to the amount ingested. When blood sodium levels rise, the thirst receptors in the hypothalamus stimulate the thirst sensation. And so ingestion of fluids will return the sodium concentration to normal levels. Now, as we discussed previously, aldosterone assists in the regulation of osmolality and blood volume, as well as sodium balance. Now, one thing to note is that estrogen also causes sodium and water retention. Sodium and fluid regulation can be disrupted in certain states, and so we do have hyponatremia, which is low sodium, and hypernatremia, which is high or highly concentrated sodium in the blood. So looking at our conditions, we have hyponatremia, which is low sodium of the blood. So this can occur with an increase in fluid without an increase in sodium. So this leads to what we discussed previously with water intoxication. This can occur in athletes or in certain psychiatric conditions as a side effect of the medication. A decrease in sodium intake, so a severe sodium restriction, and hyperglycemia. And so what happens is if a patient has high glucose in their blood, what this does is it actually will pull water from the cells into the blood vessels in an attempt to dilute the blood glucose. But when it dilutes the blood glucose, it will also dilute the sodium, thus causing the hyponatremia. Clinical manifestations of hyponatremia. So again, it'll start to be symptomatic when sodium is less than 120. Symptoms present as nausea and vomiting, lethargy, confusion, and seizures. And so the treatment is to restrict water and then to administer sodium via either an oral supplement that contains relatively high sodium, this is like your Gatorade, Gatorade Endurance, or IV if necessary. Now another strange condition that you may see is syndrome of inappropriate antidiuretic hormone secretion. So this is characterized by excessive release of the antidiuretic hormone, which results in concentrated low volumes of urine and dilutional hyponatremia as water is retained. So again, we're continuing to not urinate, and we have a buildup of fluid in the body, which dilutes, right, the sodium in the blood. So the sodium remains normal or has not changed, but total body fluids increase. Now this can be caused from central nervous system disorders, pulmonary disorders, tumors, and lung cancer, specifically small cell, head injuries, and certain medications, and so the treatment is fluid restriction. And so I have seen this most often when you're looking at is where we've started seeing this more and more frequently is traumatic brain injuries or closed head injuries. So things like severe concussions, etc. So on the opposite end of the spectrum of hyponatremia, we have hypernatremia. And so looking at causes, so a possible cause, an increase in sodium intake. However, in a healthy person, typically an increase in sodium intake results in an increase in sodium excretion, so it should kind of stay in balance. So it would have to be pretty severe or something's abnormal. This could also be caused by a decrease in water intake, so for example the elderly with decreased thirst mechanism, excessive water losses due to fever or draining wounds, or not consuming enough water, so for example athletes who are exercising and becoming dehydrated and not consuming fluids. And so again, what we're going to see is possibly hyperosmolality, so providing a IV fluid that is excessively high in sodium. Again, this is sometimes done on purpose. We'll use a 3% sodium solution, and this has to do with for inflammatory patients in ICUs. But again, it's very temporary and should not be used long term. So clinical manifestations of hypernatremia include neurological symptoms, lethargy, seizures, and coma. And so the treatment is an increase in fluid intake, IV fluids without sodium, diuretics, or dialysis. And again, the big thing is that the treatment must be gradual, as if we do this too quickly, then we'll have a rebound effect where we'll actually have cerebral edema or swelling in the brain. So our major source of sodium is from sodium chloride, or common table salt. Now sodium, though, is 40% of table salt by weight. And so this has to do with the atomic structure of sodium and chlorine. So chlorine is actually a larger, heavier molecule. So on the molecular level, it is 1 molecule of sodium, 1 molecule of chlorine, but it's not 50-50 because the chlorine actually weighs more. So by weight, it's only 40%. Now the addition of table salt, flavored salts, flavor enhancers, and preservatives accounts for a high sodium content of many processed foods, convenience foods, and fast foods. And so when we're looking at, so the adequate intake is 1,500 milligrams. We recommend that people consume no more than 2,300. And to give you an idea, though, of how much 2,300 milligrams is, that's 1 teaspoon of table salt. All right, so moving to potassium. So this is our major cation of intracellular fluid and is present in small amounts in extracellular fluid. So again, this is why we saw such a lower concentration in the serum of 3.5 to 5 milliequivalents per liter. And its functions to maintain normal water balance, osmotic equilibrium, acid-base balance, and the regulation of neuromuscular activity. And the reason why potassium is so important is that both hyper and hypokalemia have devastating cardiac implications that can be lethal. And again, it plays an integral role as the opposite end of the spectrum for the NAK ATPase pump. So looking at low potassium or hypokalemia. So again, here we have an inadequate intake of potassium or increased renal loss of potassium. So this is common with a drug class known as loop diuretics such as furosemide or Lasix. So this is not all, but most of the diuretics that end in "ide." So this causes increased urine excretion with accompanying potassium loss, and so these are known as potassium wasting diuretics. Natural licorice and chewing tobacco, so especially if somebody is swallowing the juice, so for example things like dip, can increase urinary potassium excretion, and increased loss from the GI tract due to vomiting, diarrhea, or suction. And the other way that we can see low potassium in the blood is a shift of potassium from extracellular fluid to intracellular fluid. So it's just changing location. It's not actually leaving the body. And this is due to refeeding syndrome, which we will discuss more when we discuss our ICU and our trauma patients and our metabolic stress. So the clinical manifestations of hypokalemia, we've got muscle weakness, shallow respirations, cardiovascular rhythm changes, and cardiac arrest if left untreated. And so the treatment is to increase our intake of potassium. So we do have oral potassium supplements, and they taste atrocious. But they come in, they look kind of like those little creamers that you see like at like breakfast joints when they have like you just peel off the cap and then take a shot of it. But these are potassium, and they are incredibly, I say salty tasting, but it's potassium, it's not sodium. And they taste awful. They have horrible compliance. And then our other option is that we can administer IV potassium. So looking at causes of hyperkalemia, so we've got inadequate excretion of potassium. So this is due to diseases like renal failure. Excessive use of potassium-sparing diuretics. So this is the opposite, right? Where previously we're looking at the loss of potassium. Now we're actually unable to excrete it. Shifts in potassium from intracellular to extracellular fluid, such as hemolysis or destruction of red blood cells, or catabolism and strenuous exercise, which again is breaking down, so in this case, muscle cells. Excessive ingestion of potassium, which is relatively rare. Again, the only time this would happen is if somebody's using a supplement. So people don't really get excessive potassium from things like, well, with healthy kidneys, from things like bananas, potatoes, fruits, vegetables, etc. If you're going to get it from ingestion of potassium, it's usually going to be in the form of the salt substitute potassium chloride, such as no salt or light salt, and an overconsumption of that could cause hyperkalemia. And blood transfusions or excessive IV solutions that have excessive amounts of potassium in them. So the clinical manifestations of high potassium or hyperkalemia are going to be muscle weakness, paralysis, paresthesia or tingling, cardiac arrhythmias, and cardiac arrest, again, if left untreated or severe enough. And so the treatment, glucose and insulin given to help shift potassium from extracellular to intracellular. We also have Kayexalate, which is a medication that can help your body excrete potassium. And then again, if this is a chronic issue, dialysis and a potassium-restricted diet. So potassium is readily absorbed from the intestine, with 80 to 90% ingested potassium is going to be excreted in the urine, with the remainder being lost in the stool or feces. Aldosterone released by the adrenal glands when the potassium levels are high. And so aldosterone secretion results in increased potassium excretion. So remember, aldosterone will retain the sodium and excrete potassium. And sources of potassium include fruits and vegetables, specifically fresh fruits and vegetables, fresh meat and dairy, and the adequate intake is 4,700 milligrams. So we need a whole lot more potassium compared to the amount of sodium that we need. So here you can see an example of low, medium, high, and very high fruits and vegetables. And so again, you can look at these very high sources where you're going to notice that there are things like potatoes, tomatoes, what are the other ones that people usually notice? Dried beans, right? And so then you'll see, looking at our very high fruits, you're going to have things like cantaloupe, honeydew, bananas, etc. But I think a lot of times people forget about the vegetables, and they're very, very focused on bananas. That's just good. That's just due to good marketing. There's actually quite a bit in vegetables, and specifically potatoes, which is always kind of a point of contention for patients with a dialysis diet, right, with renal disease, having to follow a low potassium diet. Now we'll take a look at calcium. So it is a normal serum concentration of 8.5 to 10.5 milligrams per deciliter. And the serum concentration depends on intestinal absorption, exchange between extracellular fluid and bone, and renal excretion. 99% of calcium is stored in the bone, with the remaining 1% in circulation for physiological function. So its functions, again, it's in bones as part of the hydroxyapatite crystals, but outside of bones it plays a role in cardiac, nervous system, and skeletal muscle function. So approximately half of all calcium found in the intravascular compartment is bound to the serum protein albumin. Now what this means is that when serum albumin levels are low, total calcium levels decrease due to this hypoalbuminemia. Now you saw this previously when we were looking at our biochemical assessments, and again, normally depending on the lecture order and how many we would accomplish in a single day, I didn't want to go over that equation though, as we had not yet discussed calcium. So here we can now see the corrected calcium formula. So again, I would include this in my pocket guide, and again, some lab reports will do this for you. Sometimes you may have to do this by hand. But it's serum calcium plus 0.8 times 4 minus the serum albumin. So you will be adding calcium, right? So with this correction, the number should go up from the number you're actually seeing on the lab report. Ionized calcium is free, unbound calcium, and is the active form of calcium, and this is not affected by hypoalbuminemia. And normal levels here, again, you're going to have a little bit different system of measurement, which is 4.5 to 5.5 milliequivalents per liter. And as serum pH rises, calcium binds with protein, leading to decreased ionized calcium levels. And as pH lowers or becomes more acidic, ionized calcium levels increase. Calcium is regulated by parathyroid hormone, calcitonin, vitamin D, and phosphorus. When calcium levels are low, the parathyroid hormone is secreted from the parathyroid glands, and parathyroid raises serum calcium levels by pulling calcium from the bone and decreasing the excretion of calcium in the urine. Parathyroid hormone stimulates the activation of vitamin D, which works to maintain serum calcium levels by increasing absorption of calcium in the small intestine. Therefore, parathyroid hormone releases calcium from bones and stimulates increased absorption from the GI tract. Now, when calcium levels are high, calcitonin, which is secreted by the thyroid gland, shuts off, or the mnemonic that I use is it tones it down, the blood calcium release, and decreases GI absorption. Phosphorus also inhibits calcium absorption within the GI tract, and calcium and phosphorus have a reciprocal relationship. So when serum calcium levels are high, serum phosphorus levels will be low, and vice versa. So here you can see this interplay and looking at the interaction between the hormones, calcium, and vitamin D. Now looking at our states, we have hypocalcemia, or low calcium. So this is a serum less than 9 or an ionized less than 4.5. And a deficiency of parathyroid hormone is the most common cause. We can also have abnormal vitamin D metabolism due to renal or liver failure, or significant changes in serum phosphorus levels. Clinical manifestations of hypocalcemia include muscle spasms, tetany, and cardiac dysrhythmias. And the treatment is to administer IV calcium. Hypercalcemia is high calcium above 10.5. This can be caused by hyperparathyroidism or the presence of malignancy with metastases to the bone. So again, a spread of cancerous processes to the bone. Clinical manifestations of hypercalcemia include fatigue, weakness, confusion, bone pain, and cardiac dysrhythmias. Treatment involves removal of the parathyroid gland, agents to bind calcium, and IV fluids to dilute calcium, along with diuretics and dialysis. So the ileum is the most important site for calcium absorption. So if somebody's had GI surgeries, this would be relevant. And the kidney is the main site for calcium excretion. So most serum calcium is bound to proteins and not filtered by the kidneys, with only 100 to 200 milligrams of calcium being excreted daily in the urine. Next, we'll take a look at phosphorus. Remember, we said this has a reciprocal relationship with calcium. So our normal serum concentration is 2.4 to 4.6 milliequivalents per liter. It plays a role in energy metabolism in the form of ATP and bone metabolism, with 80% of the body's phosphorus found in the bones. And severe hypophosphatemia can be life-threatening because of the role that phosphorus plays in energy production. Now, phosphorus is excreted by the kidneys, and hyperphosphatemia is present with kidney disease. So parathyroid hormone stimulates the resorption of phosphorus from the bone, which increases serum phosphorus levels. Parathyroid hormone also stimulates phosphorus excretion in the urine, and calcitriol, which is from our active vitamin D, stimulates phosphorus absorption in the GI tract. Now, phosphorus again is going to compete and inhibit absorption of calcium in the GI tract, and calcitonin decreases phosphorus and calcium concentrations. So with hypophosphatemia, or low phosphorus below 2.5, this can be caused by vitamin D deficiency, decreased activation of vitamin D, hyperparathyroidism, excessive aluminum-containing antacids, although most people don't really use these anymore. These are things like Malox, or a shift of phosphate from the extracellular to intracellular fluid. And this occurs during hyperventilation or refeeding syndrome, where again the phosphorus is no longer in the blood, but instead moves into the cells. So clinical manifestations of hypophosphatemia include encephalopathy and coma, and osteomalacia and rickets. And so the treatment is an oral phosphate in the form of food or supplements, and then IV phosphate, but this is only given in emergencies due to the risk of precipitating calcium, which is you can actually grow calcium crystals in your blood vessels, which is very dangerous. And calcium deposition into these soft tissues can cause organ damage. Specifically, we're looking at the heart and lungs. Now we have hyperphosphatemia, and this is in acute or chronic renal failure, and then or with low parathyroid hormone or other endocrine disorders. Clinical manifestations of hyperphosphatemia include altered nerve transmission and muscle contraction, and a well-known itch, where it feels like there's an itch underneath your skin that just really can't be scratched. The treatment is dietary phosphorus restriction, and especially in patients with chronic issues, is phosphate binders or a calcium supplement to again compete with, bind, and then encourage the excretion of phosphorus. The RDA is 700 milligrams per day with an upper limit of 3,500 to 4,000 milligrams per day. Now, phosphorus is mainly found in animal products, dried beans, nuts, cereals and grains, coffee, tea, and in colas in the form of phosphoric acid. Looking at magnesium, so the normal serum concentration is 1.7 to 2.5 milliequivalents per liter, and magnesium functions as a cofactor in many enzymatic reactions, bone metabolism, central nervous system, and cardiovascular function. Now, it is found in intracellular fluid, and 50 to 60% of magnesium in the body is located in the bone, with the remaining being found in that intracellular fluid. Magnesium is absorbed in the ileum and the distal jejunum. So again, if you're looking at patients who have had surgery, so if they have things like Crohn's disease where they're now missing portions of their intestine, this could be very relevant. And the kidney is the major regulator for the excretion of magnesium. So hypomagnesemia, so less than 1.5, and this is seen with diseases such as chronic alcoholism or withdrawal from alcohol. Medications such as cyclosporine can cause excessive magnesium losses. Malabsorption syndromes, volume overload, diuretics, low phosphorus, or high ionized calcium. The clinical manifestations of low magnesium or hypomagnesemia include depression and personality changes. And so here you'll see anorexia. Now remember that this is anorexia meaning poor appetite, not the psychiatric disorder anorexia nervosa. So poor appetite, nausea and vomiting, and an ileus, which is paralysis of the GI tract muscles. The treatment includes diet and oral supplements. Although some of you may be familiar with, but many of you are probably not familiar with mag citrate. And so mag citrate is famous for being used as a colon prep. Mag citrate has also increased in popularity as being used as a supplement on the ketogenic diet. You probably have seen what's known as Naturally Calm. And again, so taking too much of this all at once is known to cause diarrhea. So IV magnesium must be given cautiously though, as high levels can cause cardiac arrest. So again, there's a big difference between, again, an oral supplement, which is diarrhea, which is not pleasant, but again, IV also carries significant risk. Hypermagnesemia, so more than 2.5, seen in declining renal function or excessive supplementation. So specifically when patients are taking magnesium-containing antacids or laxatives, so most famously milk of magnesia. The infamous Phillips, again, used typically for bowel movements, but again, it also is very high in magnesium. So the clinical manifestations of high magnesium include nausea and vomiting, facial flushing, hypotension, impaired cardiac function, decreased reflexes, muscle weakness, and paralysis. And the treatment includes calcium gluconate, dialysis, and discontinuing any magnesium-containing medications. And so with that, we've discussed our electrolytes, and we'll move into our disorders of fluid balance. So the three general categories of fluid alterations that can occur in fluid balance, so we're going to look at changes in fluid volume, changes in fluid concentration or osmolality, and changes in fluid composition. And the reason why this all ties together, and then we'll go on to talk about acid-base balances, that changes in fluid, electrolyte, and acid-base balance are occurring together. Again, we're looking at this dynamic balance, where again, as electrolytes change, acid-base changes. As acid-base changes, right, it's usually because something's going on with the fluids, so on and so forth. So first we'll take a look at hypovolemia, which is an extracellular fluid deficit. This is usually related to renal losses of fluid through either a disease process or diuretics, or extrarenal, so from outside of the kidney losses of fluids, which includes losses of fluids such as GI losses from nausea, vomiting, and diarrhea, skin losses through burns, wounds, fistulas, or sweat, and ascites or third spacing, which again results in a net loss of extracellular fluid. So the clinical manifestations of hypovolemia is orthostatic hypotension, so low blood pressure upon changing positions. And so this is most famously right when someone is dehydrated, and so when they stand up and they get woozy. So this is weak pulse or dizzy spells or a head rush, so especially right when you've seen the little sparkles when you stand up too quickly. That's a change that is orthostatic hypotension from the change in blood pressure. You also see poor skin turgor, dry skin and mucous membranes, and rapid weight loss. So here we can see a nice little table where again we can see some of these symptoms, right? And you can see then with the change in percentages and how this is evaluated. So we see this again if we have slow pulse versus fast pulse, if we see changes in blood pressure, right? If we see jugular vein distension, etc. So looking at laboratory findings for hypovolemia, so we have hemoconcentration, so we have less fluid or liquid in the blood, so the blood becomes more concentrated, unless there is also a loss of blood. So the serum levels of sodium, BUN, hemoglobin, hematocrit, and albumin will all be elevated. The kidneys will compensate by decreasing urinary output, and as urinary output decreases, the urine will become more concentrated and darker in color. So here again we can see those lab values and those electrolytes, and again remember when we're having this hypovolemia, these numbers will become more concentrated because there is less liquid but the same amount of stuff in the blood. And so here again you can see, so looking at the urine values as opposed to the blood values, just be careful, right, if you see the milliosmoles or you see the milliequivalents, just make sure, so again as we're switching tests, just make sure you're all seeing the translation. Now here again we can see some IV fluids. So again, if we're needing to rehydrate a patient, you're going to see some combination of these. What they all mean long term we'll discuss more as we discuss IV fluids and parenteral nutrition. But again, just realizing there are multiple ways to rehydrate a patient, either with dextrose-based solutions, sodium-based solutions, there are buffered solutions, and then combinations of those. So now looking at hypervolemia, or extracellular fluid excess, here the overall blood volume is increased. Now this increases blood pressure. The most common cause is a decrease in urinary output, such as in acute renal failure. Also, excesses in IV fluids or failure of the kidney to accommodate a rapid ingestion of fluids quickly enough. Possibly an excessive secretion of vasopressin, which can cause this volume retention, or an accumulation of fluid in the interstitial spaces, or edema. Now, the clinical manifestations of hypervolemia or too much fluid includes elevated blood pressure, pitting edema, so the indentation of the skin that will result when pressure is applied to the area, and this is put on a scale of 1 to 4, so again with a finger imprint, how long it takes to rebound. Dyspnea, which is difficulty breathing. The presence of RALS, which is the bubbling or crackling noise with the lungs. So when we are back on campus, we will be learning physical assessment. I don't need you to determine the severity of the RALS. I do need you to be able to hear them, which is, again, the reason why this matters from a nutrition standpoint is that this patient is retaining so much fluid that it is now actually going through the membranes and ending up in the lungs. Now you'll also see weight gain in these patients, remembering that 1 kilogram of fluid takes up 1 liter. So if a patient has gained 10 pounds, that's somewhere in the neighborhood of 4 liters of fluid extra in their body. So here you can see the pitting edema. So again, you can see the depth and timing it takes to rebound. So the laboratory findings for hypervolemia. So we'll see hemodilution. So again, we're going to see a decrease in sodium, hemoglobin, hematocrit, BUN, and albumin. And the treatment for hypervolemia involves the restriction of both fluids and sodium. So in conclusion, when it comes to fluid and electrolytes, we want to assess for factors that can affect fluid and electrolyte balance, including the presence of disease or injury, medication or treatments, is there any known source of fluid loss, nutrient restriction, oral intake, and then looking at the I's and O's or intakes and outputs to see if they are balanced. Next, we'll take a look at acid-base balance. So the maintenance of normal pH allows for normal cellular function, enzyme activity, and membrane stability. The maintenance of blood pH within the normal range of 7.35 to 7.45 is crucial for many physiological functions and biochemical reactions. Now remember that acid-base balance is in dynamic equilibrium. So again, this is looking at our hydrogen ion concentration and this balance, right? So it's constantly shifting a little towards each direction. So the disruption of acid-base balance occurs when acid or base losses or gains exceed the body's regulatory capabilities, or when normal regulatory mechanisms become ineffective. Disturbances may develop due to certain diseases, toxin ingestion, shifts in fluid status, or certain medical and surgical treatments. If acid-base balance is left untreated, multiple detrimental effects can occur, ranging from electrolyte abnormalities to death. So let's take a look at acids. So these are substances that donate or give up hydrogen ions. Now there are 2 types of acids. There are volatile acids, which can be converted to the gaseous form and eliminated by the lungs. The most prominent of these is carbonic acid. So we produce this in the largest amount, approximately 20,000 millimoles per day, and this is a major source of hydrogen. Now carbonic acid is what happens when we dissolve CO2 in the blood. So CO2 is used as an indirect measurement of acidity, since carbonic acid is not possible to measure the exact concentration in the blood. But again, when we dissolve the CO2 into the blood, it becomes the carbonic acid. So again, kind of similar to that functional assay, it's closely related to the thing we are trying to assess. We also have non-volatile or fixed acids. So these are the end products of carbohydrate, protein, and lipid metabolism, and these are unable to be eliminated by the lungs. These on average, though, are in much smaller quantities at 50 to 100 millimoles per day. And protein metabolism contributes the most, with the addition of inorganic acids such as phosphoric and sulfuric acid. Organic acids include lactic acid and keto acids, and these are produced as a result of starvation, fasting, fever, intense exercise, and some disease states. Looking at bases, so these are substances that can accept or receive hydrogen ions. Bicarbonate is the most predominant base involved in human acid-base balance, and the kidneys provide the primary regulation of bicarbonate, so they control the amount of bicarbonate that is removed or retained in the body. Now we'll also discuss buffers. So these are substances or a group or a category of substances that react with either acid or base in order to decrease the effect of the acid or base on the pH of a solution. And so what you'll see is that buffers are typically weak acids or bases, and so they minimize the effect of strong acids or bases. Now buffers are present in all body fluids, and proteins and phosphates are the primary intracellular buffers. Bicarbonate and carbonic acid are the primary extracellular buffers. Now here we can see the bicarbonate carbonic acid buffer system, and this accommodates more than 80% of the buffering in extracellular fluid. And so here we can see hydrogen ions and bicarbonate, along with the formation of carbonic acid, and then CO2 and water. Now the lungs will accommodate increased loads of acids by increasing the rate and depth of breathing. So you'll breathe faster and deeper to remove CO2 or carbonic acid. The kidneys will regulate bicarbonate resorption and the secretion of hydrogen ions. So you will actually secrete hydrogen ions through the urine. Now there are other chemical buffers in the body, and so here again we discussed the bicarbonate carbonic acid, and here you can see the protein buffer system, the hemoglobin buffer system, and the phosphate buffer system. So looking at pH, so this is the unit for measuring relative acidity or alkalinity of a fluid, and so pH essentially is our ratio of acids to bases. Now the pH ranges from 1, which is extremely acidic, to 14, which is extremely basic. Water is neutral at 7.0, and the normal serum pH, or the blood pH for humans, is 7.35 to 7.45. And this is where I make the joke that we're all a little bit basic. So here you can see the scale, and so you can see on one end of the spectrum we have battery acid, and on the other end of the scale we have concentrated lye. So water you can see is neutral, whereas saliva is slightly acidic. Gastric juices are quite acidic, and then you'll see that bile and pancreatic juices are slightly basic. Now terms to describe pH, so we have acidosis, which is the process that leads to the accumulation of acid or a loss of base, and acidemia is a condition where there is an actual decrease in the pH within the body, or specifically in the blood, to less than 7.35. Alkalosis is the process that leads to the accumulation of base or a loss of acid, and alkalemia is a condition when there is an actual increase in the pH of the blood to greater than 7.45. Now looking at our evaluation of acid-base status, so we're going to look at serum electrolytes and arterial blood gas values, or ABGs, and pH. Now the body is constantly attempting to correct pH, so it may appear normal even under acid-base disturbances, and this is what's known as compensation. Therefore, it's important that we look at all of the other markers and the patient's condition as well. So looking at blood gases, so blood is taken from an artery where the oxygen and carbon dioxide levels can be measured before they enter body tissues. So typically when we're getting measurements, we're getting blood from veins, but here specifically we want to see before it's exposed to the tissue. So again, this is unique in that we are taking blood from the radial artery in the wrist, the femoral artery in the groin, or the brachial artery in the arm. So here we get a measurement of how much oxygen and carbon dioxide are in the blood, and helps us determine the acidity of the blood. Now abnormal results though may be due to lung, kidney, or metabolic diseases. So again, while we know there is something wrong, we still don't necessarily know the source. Some other important terms to look at, you'll see when we're determining acid-base balance, is the partial pressure of oxygen. And this is the measurement of the pressure of oxygen dissolved in the blood and how well oxygen is able to move from the lungs into the blood. We also have the partial pressure of CO2. And this is the measurement of how much CO2 is dissolved in the blood and how well is it able to move out of the body. Again, we'll be looking at bicarbonate. Again, this is the chemical buffer that keeps the pH of the blood from becoming too acidic or too basic. And oxygen saturation, or O2 sats. And so oxygen saturation measures how much of the hemoglobin in the red blood cells is actually carrying oxygen. So here we have our normal ranges for our ABGs, including our pH, our partial pressure CO2 and O2, our bicarb, and our O2 sats. Now looking at our acid-base disorders, there are 4 major types of acid-base disorders. You have respiratory acidosis, respiratory alkalosis, metabolic acidosis, and metabolic alkalosis. Now it is possible for a patient to have multiples of these disorders, so when they occur together we have what's known as a mixed disorder. Here is a very handy cheat sheet, and I strongly recommend that you keep a copy of this in your pocket guide, as it basically has all of the information that you need and that I'll be discussing in one nice, neat little digestible sheet. So first we'll take a look at respiratory acidosis. So this occurs due to excessive acid in the blood secondary to carbon dioxide retention. This is characterized by low blood pH, so that's being more acidic, usually due to respiratory dysfunctions as the lungs are unable to expire CO2, hypoventilation, and acute respiratory distress syndrome. Renal compensatory mechanisms work to increase the excretion of hydrogen ions and resorb bicarbonate. Here we can see some additional causes of respiratory acidosis. So for respiratory acidosis, the labs will represent with decreased pH less than 7.35 and elevated PCO2. There will be slightly elevated bicarbonate if renal compensation has begun, and there will be an increase in serum calcium, potassium, and chloride. Symptoms include hypercapnia, which is an excessive amount of CO2 in the blood as the levels of CO2 rise, along with restlessness, apprehension, lethargy, muscle twitching, tremors, convulsions, and coma. The treatment requires correction of the underlying condition and increasing oxygenation through the administration of O2 or mechanical ventilation. So what you'll see is with many of those disease processes as the patients put on supplemental oxygen. You're probably most familiar with the nasal cannula that you'll often see. So elderly with lung disease will wear. That again goes under the nose and over the ears to provide additional oxygen. Next we'll take a look at respiratory alkalosis. And so this occurs due to relatively excessive amounts of base, such as bicarbonate, due to a reduction of CO2, resulting in alkalemia. Now this is usually due to conditions causing hyperventilation. So this is caused by hypoxemia, which can be a result of respiratory diseases such as pneumonia, asthma, high altitudes, pulmonary edema, and anxiety. So in this case, right, remember we've excreted too much CO2 because we're breathing too quickly. Now in response, the shift of acid from intracellular fluid to extracellular fluid occurs, and bicarbonate is moved into the cells in exchange for chloride. Now renal compensation may occur if this lasts longer than 24 hours, and the kidneys will increase the amount of hydrogen ions secreted and increase bicarb excretion. Here we can see some common causes of respiratory alkalosis. So respiratory alkalosis is characterized by a pH greater than 7.45, and PCO2 will be decreased. Plasma bicarbonate will be low in chronic respiratory alkalosis due to the compensation. The electrolytes will present with low potassium and calcium and high chloride. There will be cardiac, central nervous system, and respiratory symptoms, and you'll see frequent yawning, deeper breaths, lightheadedness, mental confusion, anxiety, seizures, and paresthesia or tingling. The treatment again requires treating the underlying condition and the correction of hypoxia by providing O2 therapy. Next, we'll take a look at metabolic acidosis. And so this refers to all types of acidosis not caused by excessive CO2. So here we have an excessive loss of base bicarbonate or an excessive gain of non-volatile acids. So diarrhea is the most common cause, but can also be due to losses from ileostomy or from pancreatic, biliary, or intestinal fistulas. Common causes of metabolic acidosis are seen below. And again, metabolic acidosis is characterized by a pH less than 7.35, resulting in acidemia, right, or an increased acidity of the blood. High levels of hydrogen ions stimulate bicarbonate carbonic acid buffering system with a shift of hydrogen ions from intracellular fluid to extracellular fluid. The lungs will increase the rate and depth of breathing, and the kidneys will compensate by increasing the excretion of hydrogen ions and retaining bicarbonate. There will be cardiac and neurological symptoms, and the patient will have what's known as Kussmaul breathing, which is rapid, deep, labored breathing, and the symptoms will present with hypotension, dysrhythmias, lethargy, stupor, coma, growth failure, and renal osteodystrophy. Again, the treatment is to treat the underlying cause, and we need to raise the pH to the safe levels, but not too quickly. And so we do need to measure the anion gap. So in metabolic acidosis, the anion gap is calculated to help determine the cause and appropriate type of treatment. And so this is the difference between routinely measured cations and anions in the blood. And so this is sodium and potassium ions minus chloride and bicarbonate ions. And the normal range is 12 to 14 milliequivalents per liter. So when we have anion gap metabolic acidosis, this is when the anion gap exceeds the normal range due to increased acid ions and ions other than chloride. These conditions include what's known as mud piles, methanol ingestion, uremia, diabetic ketoacidosis, paraldehyde ingestion, iatrogenic causes, lactic acidosis, ethylene glycol, and salicylate intoxication. For non-GAP metabolic acidosis, this occurs when a decrease in bicarbonate concentration is balanced by an increase in chloride concentration, resulting in a normal anion gap. And this is used carp, such as ureterosigmoidostomy, small bowel fistulas, extra chloride ingestion, diarrhea, carbonic anhydrase inhibitors, adrenal insufficiency, renal tubular acidosis, and pancreatic fistula. Looking at metabolic alkalosis, so this occurs due to an excessive amount of base or bicarbonate, resulting in alkalemia. And this is caused by an administration or accumulation of bicarbonate, for example, over-administration of bicarbonate with blood transfusion, an excessive loss of acid, for example, gastric suctioning or vomiting, loss of extracellular fluid containing more chloride than bicarbonate, for example, villus adenoma and diuretic use. This may result from volume depletion or severe hypokalemia. Here we can see some additional causes of metabolic alkalosis. So with metabolic alkalosis, the kidney will compensate for a decrease in non-volatile acid by generating hydrogen ions and decreasing reabsorption of bicarbonate. This is characterized by a pH of greater than 7.45 and elevated bicarbonate. With the electrolytes, we may see low potassium and chloride. And if there's respiratory compensation, we may see elevated CO2. Now, there's no specific signs and symptoms, but again, we can look at electrolyte imbalances and fluid shifts. And our treatment again is focused on the underlying condition. The volume imbalance can be corrected with isotonic saline with potassium chloride and carbonic anhydrase inhibitors in severe cases to enhance bicarbonate excretion. We also have our mixed acid-base disorders, and so several acid-base disorders can coexist in complex medical problems. This is likely when the PCO2 and bicarbonate are not consistent with the measured pH. This may be present when the compensatory response is exaggerated. So for example, metabolic alkalosis and respiratory acidosis may occur when a COPD patient is receiving diuretics. Here you can see some examples of dual or mixed disorders. Again, I would likely keep this cheat sheet with me in my pocket guide because again, this is some of the more complex patients. Again, I'm not asking you to memorize this, but again, that you can see when patients come in that are very ill with multiple conditions, this is what can occur. All right, so let's take a look at some practice questions. So insensible water losses are lost via the, and that is answer choice D, lungs and skin. Number 2, major intracellular electrolytes include, and that is answer choice C, potassium is in the cells. Number 3, causes of respiratory acidosis include, and that is answer choice A, decreased ventilation. Primary extracellular buffers are, and this is answer choice B, bicarbonate and carbonic acid. Question 5. The main hormone that regulates sodium balance is, and this is answer choice B, aldosterone. So remember, antidiuretic hormone is focused on fluid, aldosterone is focused on sodium. And there you can see in case you have additional questions. And I thank you for your time, and I look forward to your questions.